These are very short. When you think of chest trauma, just be aware that the patient will have multiple chest traumas occurring at the same time. Meaning, if you look at the anatomy, we have the chest wall, and then underneath that is, of course, some muscles. Well, subcutaneous first, and then there's muscles, and then there's the ribs, and then you have the pleura, and then you have the lung. So for a patient to sustain an injury to the lung, there has to be injuries before it gets to the lung first. So for instance, they may suffer broken ribs along with the pulmonary contusion and so on. Does that make sense? Meaning the patient will have multiple injuries here. So let's say in a pneumothorax, for instance, or a hemothorax, that means the patient will have to have pulmonary contusion, meaning you have to injure the lung in order to introduce air or blood into the pleura. Does that make sense?
Yep.
Okay. So let's start with pulmonary contusion. So questions on the exam will be simple. It's how do I recognize it? Because the patient comes into the ER based on the symptoms. How do you know that the patient has a pulmonary contusion? And then the other question is, what do you do about it? So those are basically the two questions on the test. For each chest trauma, you're asked to identify how do you know that it is happening? What are the signs and symptoms? And then what do you do about it? Or it could also include what do you not do about it? So let's begin with pulmonary contusion. Ms. Lachenpa, what is pulmonary contusion and what are the signs and symptoms?
It is a potentially lethal injury, a common chest injury, and occurs most often by rapid deceleration during car crashes. After a contusion, respiratory failure can develop immediately or over time. Hemorrhage and edema occur in and between the alveoli, reducing both lung movement and the area available for gas exchange. Localized inflammation.
All right, let's go straight to signs and symptoms now. So how will the patient look to you? Go to the next paragraph.
So the patient may be asymptomatic at first and can later develop various degrees of respiratory failure and possibly pneumonia. They'll have decreased breath sounds or crackles and wheezes over the affected area. Other symptoms include bruising over the injury, dry cough, tachycardia, tachypnea, and dullness to percussion.
All right.
Do you want me to keep reading? Oh.
It's okay. The rest are on the chest x-ray already. So you'll have symptoms inside and also outside. Obviously, the bruising here are visible to you. So you can see the bruising over the injury. However, inside, the only symptoms you'll see or signs are the lung sounds and, of course, the chest expansion. Okay, those are the only things that are visible, observable, because you can't see the rest. They're all inside the rib cage. What do we do about it, Mr. Beecher?
Oh, sorry. So the management would be maintaining ventilation and gas exchange, providing oxygen, giving fluids as prescribed, putting the patient in moderate Fowlers, increasing, I guess, monitoring the FiO2, and putting the patient good lung down.
Okay.
And monitoring their respiratory status, and if needed, it looks like doing the non-invasive positive pressure ventilation or the mechanical ventilation.
Okay, thank you, sir. And that's it. So we move on to rib fracture. The vicious cycle here, we already described that last week under respiratory failure. Rib fracture. There are two types here. We have a rib fracture and flail chest. So when is it called rib fracture and when is it flail chest?
flail chest, the even movement, like paradoxal movement, like one goes up, one goes down.
All right, very good. So to just bear with my, can you see the whiteboard?
Yes.
Okay, so just bear with me here. So let's say that is your collarbone, and that's your sternum, and we have at the back. Let's do a sideways here. So let's say this is the head, and then the spine at the back. So this is the spine. So the ribs obviously are anchored anteriorly to the sternum and then posteriorly to the spine. So just draw one side. This is getting worse the more I draw this. So this is anchored there. No, this is terrible. But you can see the picture, right? And just use your imagination. All right. So we have ribs connected to the sternum anteriorly, and then they're anchored to the back on the spine. So we have our rib cage. A fracture is if it's broken in either, it can be more than one place, but there is no displaced fracture. In a non-displaced fracture, there can be multiple broken ribs. However, if it doesn't affect chest expansion, meaning there is no independent section, meaning none of them are displaced. Or let's say if one is displaced, so let's say this one on the left. So this is, imagine this is a rib. Okay. It's broken here, or let's say even it's displaced. However, they're still anchored. At least a section of them are still anchored, meaning this piece here is still anchored to the sternum. This other half, this other piece is still anchored to the vertebrae. That's still a rib fracture, because the lung inside it will still be able to, let's say this is now your lung, it will still be able to expand, and the ribs will still aid it. Okay, the chest can still expand because this is again anchored, it's still here. And then this one is also still on the spine. So imagine the lung expanding, it will still allow the chest to expand. Of course, there will be pain. It's painful when the patient takes a breath because this part here is broken. So every time the lungs press against that broken segment, it's painful. Right? So it's painful when the patient takes a breath, but at least the lungs fill with air, they expand, no problem, except for the pain. In a flail chest, you have now an independent section or segment. To describe it, so let's say it's this one right here. So this part here is still anchored to the sternum. However, you may have a broken segment that is neither attached here nor attached to the spine. So you have a section that is kind of floating. It's there because it's attached to the muscle. It can't go anywhere. It's not going to drop down here. It'll still be there, but it's now broken. You have an independent segment, meaning as the lung expands, this part here moves, the other part moves, not this independent section here, because this one it's neither connected here, neither is it connected here. So nothing is holding this segment right here. There could be multiple. This could be one, this could be another segment. There could be multiple here. Depends on the injury. Are you with me so far? So this is now a flail or an independent segment. This will not move. These three segments here that are neither connected here nor connected to the spine, meaning they are a broken segment. Think of it as a bridge. So let's say these are the two pillars of a bridge. And this part of the bridge is connected to this side, this part is connected to that side. Nothing is holding this section right here. Does that make sense?
So is it lined in?
Yeah, you have an independent segment here, neither connected to this side nor connected to this side. So if therefore, as the chest moves, this one will cave in. As the patient takes a breath, it will suck in. And when the patient exhales, this will puff back out. That's what we call a paradoxical chest movement. That's what it's described here in the flail chest. You have paradoxical chest wall movement. So here you have an independent broken segment. So every time the patient breathes, because nothing is holding that broken segment or segments, they will cave in during inhalation and then puff back out during exhalation. So it will go to the opposite side. So this is the affected side. When you take a breath, of course, air fills this part, but because nothing is holding this, it's supposed to expand the chest, but because there's nothing, it will result in a caving in. So you literally see the patient's chest wall suck in or cave in during inhalation. You'll see it. It's strange. When you feel that segment, you feel soft segment, a soft section as the rib is still there, but it's not, because it's not connected to the sternum and to the spine. It's an independent floating segment. It's just there because it's attached to the muscle. It will still be there, but it won't help with chest expansion anymore. It will actually impair chest expansion. So remember, you have the heart right here. The heart is right in the mediastinum. So every time the patient takes a breath, it will deviate the whole thing. So the trachea will deviate. You'll also see decreased cardiac output, blood pressure drops every time the patient takes a breath, because all these vessels here, imagine they're not pictured here, are the vessels of the heart. The heart is not pictured here. So imagine the superior and the inferior vena cava also being compressed here. So cardiac output will be impaired in a flail chest. So this is now a medical emergency because cardiac output will drop. And the same thing, so questions on this will be signs and symptoms, and then what do you do? Take note of the splinting. It'll be different if there's no rib fracture. If there's a bruising, that's fine. You can put a support. However, when you have a confirmed rib fracture, it should not be splinted, because splinting it will actually impair chest expansion. So that's why here splinting reduces breathing. So therefore, you must not splint the chest, meaning you don't put a bandage around it. All right, because that won't help.
Professor, so you're saying when there is no fracture, you don't splint, right? But if there is if there is a fracture, you don't splint.
Yeah.
Okay, sorry,
right,
thank
right.
you.
Management of uncomplicated rib fractures is simple because fracture rays reunite spontaneously, meaning you have no displaced fractures here, so they can heal by themselves. Otherwise, they will be treated with any other fractured bone. Screw, splints, internal reduction, same thing as if you break your leg or your arm, for instance. But if it's uncomplicated, meaning it's intact, it's not it's not intact, but it's non-displaced, right? You just have a crack there, a non-displaced fracture. So you don't splint that. You do give patient pain medication. However, that is accomplished either nerve block or just oral analgesics, for instance. So this one is now different. Flail chest is a emergency. You have to, because this one, will impair cardiac output already, so the patient needs emergency surgery to fix that. And as already mentioned earlier, the patient may not have only one chest injury here. So you may not have rib fracture or flail chest only, because these, as whatever force caused the flail chest or the rib fracture, remember it has the potential to hit the lung. So the same blunt force trauma that broke the rib will cause that. Let's say there's a broken rib, there's an actually displaced broken rib. That sharp edges of the broken rib may puncture the lung, causing air and blood to enter the thorax now. It enters the pleura. So now we have our next problem, which are pneumo if it's air, or hemothorax if it's blood. Or if you have both, then it's a pneumo-hemothorax. A tension pneumothorax is depending on how fast the pneumothorax developed and also the nature of the injury. Show you a video on tension pneumothorax. So a tension pneumothorax is another surgical emergency. There's a short animation here. Can you see the YouTube video?
Yes.
Okay. So here you have a small hole in the lung. So let's say this is the hole created by the rib fracture, which was displaced and then punctured the lung. Or in the case of COPD patients, they can also develop what's called spontaneous pneumothorax, because some COPD patients will have blebs. Blebs are like air-filled blisters on the surface of the lung parenchyma. So those blisters rupture, then now causing a hole in the lung. So with each breath that the patient takes, air escapes, and that air has nowhere to go. It gets trapped within the pleural sac. So you can see here the size or the expansion of the right lung is considerably smaller compared to the left as a result of this positive air, this positive pressure rather, that's accumulating in the pleura. So watch the lung collapse progressively worse and worse with each breath. Each breath here will add to the amount of air trapped in here. And then watch what happens to the alignment of the trachea and the mediastinum as that occurs. So as the lung collapses, it will go to the contralateral side. So it will go to the contralateral side, causing the mediastinal shift and tracheal deviation. So as it progresses, this can cause shock. This falls under obstructive shock. So the lung collapses worse and worse, impairing gas exchange. And as the mediastinum shifts, cardiac output will drop.
Professor, are you there?
Any question?
We didn't hear what you just said, Professor. Most of it was a blur.
I wasn't speaking anyway. I was just showing the animation. So here is the tension pneumothorax. The signs and symptoms are, of course, since the lung is collapsed, will you hear any breath sounds at all?
No.
No, there will be absent breath sounds on the affected side. So the worse the lung collapse gets, then the more absent the lung sounds become. And of course, you'll see obvious tracheal deviation. So you'll see this and the mediastinum also. So when you feel for the PMI, what is the PMI again? Or where is the PMI?
At the apical pulse of maximum.
Give me a exact anatomical landmark.
Fifth intercostal and the mid-clavicular on the left side.
Very good. So will you still feel the PMI at that point if the mediastinum shifts?
Probably not.
You will now see the PMI move toward the mid-axillary area now. Other symptoms are distended neck veins because the blood is unable to return from the head down back to the heart because now you squeezed everything. So so as the mediastinum shifts because of the increased pressure on the affected side, that will compress the big veins, the big vessels, causing shock. That's your hemodynamic instability. And therefore, this is an emergency. A simple pneumothorax is not necessarily an emergency, but a tension pneumothorax, which is possible in every pneumothorax, is a surgical emergency. So when taking care of a patient with pneumothorax, what should you always be monitoring the patient for? Ms. Sanchez.
I'm sorry, what was the question again?
So when you're caring for a patient with a pneumothorax, what should you always be monitoring the patient for?
The respiration.
All of these right here.
So extreme respiratory distress cyanosis, distended neck veins, and hemodynamic instability.
Mm-hmm. Any question on pneumothorax? Again, a pneumothorax is not necessarily life-threatening, but a tension pneumothorax characterized by these right here is an emergency. Is that clear?
Yes.
All right. So let's go now before we go to chest tubes, which is most likely what these patients will receive. For a tension pneumothorax, the initial management is because a chest tube insertion will take about 5 to 10 minutes to perform. This patient doesn't have 5 to 10 minutes. This patient will die within 1 minute unless you relieve that tension inside the patient's chest wall. So to relieve that pressure, the procedure is called needle thoracostomy. This is not the same as chest tube insertion because chest tube insertion is called the chest tube insertion procedure is called chest thoracotomy, meaning you are making an opening in the chest wall. This one, you're just inserting a needle. The procedure, again, this is not the same as chest tube insertion. Chest tube insertion is called chest thoracotomy. Needle thoracostomy is the insertion of a large needle, 14, 16 needle, precisely in the second intercostal space, mid-clavicular line, to relieve the air. So the air escapes from the pleural space, allowing the lung to re-expand, not fully re-expand because not all the air will escape. Plus, remember, the air is constantly filling the pleural space. Okay. Remember this part here? As the air right here, as the air escapes, all the doctor did was insert a needle here to allow this air that is constantly coming out of the lung to also come out of that needle through the chest wall. However, this is not a one-time thing. This is not a one-shot and then it fixes the problem. It won't be a permanent fix. It's just a life-saving emergency procedure to allow the lung to re-expand, relieving pressure on the mediastinum, on the heart. That way, cardiac output, venous return resumes, cardiac output resumes. Okay, but remember, there's a hole here which has not closed yet. So this will constantly cause air to come out of the lung and get trapped within this one. But we can't leave that needle in there forever. So the patient will now need a chest tube in order to drain this fluid until this hole spontaneously closes in a matter of days or maybe a week. Any question? Hello?
Yes, Professor. So
Any
the hole will close spontaneously by itself?
Yes, well, of course, depending on the size of the hole. If the hole is big enough, then the patient may need surgery. But for small holes, let's say for a spontaneous pneumo, for instance, those are small. They heal spontaneously, but it will take maybe a few days or maybe a week or over a week. Until then, you just need a way to evacuate the air out of the pleural space to keep the lung expanded. And this is where chest tubes come in. So that is now the end of 32. We will go back to chapter 30 for chest tube management. Chest tubes is in lung cancer. They put it here because after surgery for lung cancer or for any surgery involving the chest, that will include open heart surgery as well. So any open chest incision, open chest surgery will require chest tube insertion in order to drain fluid, air, or blood out of the chest wall. Okay. Can you see figure 30-14?
Yes.
Yeah.
Yes.
All right. Please take note that the tube is not in the lung. Okay. So if you look at the pleura, this is the pleura right here, which is colored, what is this? Pink? What color is this?
And
I don't know what color that. Anyway, this is the pleura. Look at the shape of the pleura. The way the textbooks describe this is, it's like a balloon that you insert your fist into. It's like an inflated balloon. So imagine a wobble bubble. Who knows what a wobble bubble is? My kids are crazy about it. So it's like a big balloon, and then you put your fist into it. The fist here, of course, is the lung. So this is like a balloon an inflated balloon, and then you put your fist into it. That's the shape of the pleura. So the pleura has two sides. This side is attached or is rubbing against the lung. So this is called the visceral surface, the visceral side. And this one, which is not in contact with the lung, this is the parietal surface. Inside that pleura, inside that balloon, is is called the pleural fluid. So the pleural fluid is about 10, 20 milliliters of water that is constantly produced and drained. The purpose of the fluid is, of course, for lubrication because the lungs move. So this is similar to any other connective tissue around the heart, around the peritoneum, around the joint, around the testicles, around the brain. Okay, so we have any moving part needs lubrication and a way to contain that lubricant. So this is now your pleura, one example. So the tube is inserted in the pleura, not into the lung. It's only in the pleura because the air, the fluid, the blood, which is now pneumothorax, hemothorax, or pneumohemothorax, or it could also be lymphatic fluid. In the case of cancer, let's say a patient has any lymphoma or lung cancer, for instance, lymphatic fluid can accumulate in the pleura as well. If it's lymphatic fluid, it's called chylothorax, C-H-Y-L-O, thorax. Again, if it's a lymphatic fluid, it's called a chylothorax. Either way, we need to remove that air, fluid, or blood, or lymphatic fluid that accumulates there because we don't want it there, because what will happen to the lung if you put anything other than the 10 to 20 mLs of fluid in it?
It's compressed.
It's going to collapse the lung because it will occupy space. It will prevent, therefore, the lung from expanding in the thorax because now you have fluid, air, or blood, or lymphatic fluid in that pleural space, which should not be there. It should only be for the lung to fill and expand. If you add those matter there, the air, fluid, blood, or lymphatic fluid in the pleura, of course, those things will occupy space. It will compete with lung expansion. So this is where we insert the chest tube. Let's watch a short animation so we can visualize the insertion, and also you can see how it is connected to a chest drainage system. So this is our typical commercial chest drainage system. This is made by Pleurovac. They have different types. We'll discuss them shortly.
The first step in the placement of a chest tube is to identify the insertion site. The insertion site is the fifth intercostal space just anterior to the mid-axillary line on the affected side. This can be found by using the nipple level as a landmark for the fifth intercostal space. In females, always be displaced inferiorly due to large annulus breasts. In this case, remember to stay above the inferior mammary fold where the nipple would normally lie. The patient lies in line. Position the hand up and over the lateral shoulder.
The intentful will not be supine for chest tube insertion. If you remember the signs and symptoms, everything.
We can't hear you.
If you remember in the textbook, what are the signs and symptoms if a patient has a hemothorax or pneumothorax?
Absent presence.
Yeah, so are they breathing comfortably?
No.
So can they tolerate being supine for the procedure?
No.
Okay, so most patients you'll see are in high Fowlers or even leaning forward, right? So this is the video you're watching is just for demonstration purposes.
And to keep it out of the surgical field, surgically prep and drape the chest at the predetermined site of tube insertion. Using a small gauge needle, locally anesthetize the skin and subcutaneous tissue and the periosteum of the underlying rib. If possible, the pleura just past the rib should also be anesthetized. Make a 2 to 3 centimeter transition parallel to the line of the ribs at the predetermined site with an number 11 cell. Dissect the subcutaneous tissue with the scissors for key sack. Exact over the top of the underlying rib until the next nice intercostal space is encountered. With the tip of the hemostat, puncture the parietal form, pushing just at the top border of the rib. Always into the pleural space over the top of the rib, so damaging the neuroaxial bundle that lies along the groove at the inferior border of each rib. Be sure to enter the pleura in a controlled fashion to avoid lacerating along the hemostat. Once inside the pleura, spread the hemostat and withdraw it slowly to create constipation in the pleura. Break the chest tube. Move your finger around 360 degrees to confirm where engaged in the closed space by feeling the bone, making sure that there are no adhesions or weakness to placing the chest tube. In the large chest tube, the number 36, number 40 trench is used to evacuation of blood and clots.
You see these holes here?
Yep.
Okay, these are the drainage holes. In your textbook, they will be called eyelets. Eyelets as in eye, your eye, small eyes like piglets, eyelets. These are called eyelets. They should be inside the patient's chest. When you see these eyelets outside, that is a emergency. You need to notify the physician because, of course, if this is partially out, remember, this is the patient's chest right here. And you see this hole sticking outside. That means air can enter the hole and then go into the patient's thorax, into the pleura, causing a large pneumothorax. Is that clear?
Yes.
Okay, so later when we go to the chart for managing chest tubes, this is one of those emergencies where you call the doctor when there are visible eyelets.
Still ends of the tube for insertion. Needle is rushing out before it can be connected to a collection chamber. The proctor will assist in chest tube insertion, but may not always be necessary or helpful. Advance the chest tube into the pleural space to the desired length. All the drainage holes should be well inside the chest cavity to provide a proper seal and prevent leakage. The chest tube should be positioned posteriorly and aimed superiorly in the chest cavity. In this defined position, it may be possible to see volume of the chest tube with expiration, and it may be possible to listen for improved air on the affected side. Connect the end of the tube to an underwater seal apparatus collection chamber.
All right. Okay, we're back here now. So you saw where the chest tube is inserted. Patient may have multiple tubes, which is not uncommon in open heart surgery. So in the case of open heart surgery, the tubes will be in the mediastinum. They will be here in front, not on the back. But for lung surgery, again, you may have multiple. Doesn't have to be one. or sometimes the patient will have both pneumo and hemothorax. The doctor may put 2 chest tubes inside. Both tubes may be connected to the same drainage collection chamber, or they may each have one, but they can be into one, because all you're draining from the chest tube, which is inserted higher, is air anyway, so it's not going to occupy any space in the drainage collection chamber. It may be necessary to put two chest tubes if you again have 2 matters there. You have air and liquid, because if you put it down here, you can only get the liquid, and the air is up here. You cannot drain air if it's already up higher in the chest. So this tube won't suck that one up. So therefore, you may need 2 chest tubes depending on the patient's condition. So let's go to the, this is the 3-bottle system. This is based on the 3 bottles which we okay, this is the 3-bottle system we use in the third world. I've seen this also in nursing homes, but that is rare, because here we use the commercially available chest drainage system. Anyway, the concept is the same. Can you see the picture? 3 bottles.
Yes.
Okay, so here, if you're just draining liquid, that could be lymphatic fluid, blood, or serous fluid accumulating in the chest of the patients. All right, so this is your bottle number 1, bottle number 2, bottle number 3, and you have the suction source. Okay, from the top, if you're only draining liquid, could be blood, lymphatic fluid, or serous fluid, you technically need just 1 bottle, because that's all you need. So from the chest, you put it into a container, and for air displacement to occur, you'll have a vent here, allowing air to escape, thereby allowing air displacement. So fluid will drain by gravity. But we can't wait for gravity to do its job, because we can't have the patient staying unnecessarily long in the hospital. We need to make sure the patient gets discharged as soon as possible. We have to add a 3rd bottle. There has to be suction. If there's also air in there, you need a 2nd bottle. The 2nd bottle is like your air trap, or this is also called water seal, meaning air is allowed to escape in water, but it cannot return to the water. To understand the concept, and you'll never forget this, so let's say Miss Williams is in the pool. Okay, so Miss Williams is here. She's wading in the pool. If she farts, can the fart escape and come out of the pool?
Yes.
Yes. If Michael is above the pool. He's on the ladder here. Let's say there's a ladder and handrails. He's on there. He's not in the water. And if Michael attempts to fart into the pool, can Michael do that if he's not in the pool?
No.
No. So when Michael farts, the air will escape right away. But Brittany, since she's in the pool and she farts, the fart will bubble out of her rectum and then escape out here and then go through here following and then etc. Okay, so it's impossible for air to go back into the patient because you have this water seal right here. And again, to facilitate the drainage of air, fluid, blood, serous fluid, lymphatic fluid, we need a third bottle, which is now your suction control bottle. Bear in mind, it's not called a suction bottle, but I said it's a suction control bottle. The reason is it doesn't provide suction. It's a bottle. It's not going to apply any suction. However, it can control the amount of suction being applied to the patient. You still need an external suction source. This could be the wall suction or it could be a portable suction. Regardless, you need a suction source in order to facilitate the drainage. This is a wet setup. It's called wet because it's based on the third bottle. The third bottle here is wet. It has water in it. How it controls the amount of suction is dependent on the height of the water in that bottle. To illustrate, Miss Zahida, have you walked with your kids in the kiddie pool at Sesame Place? Is Harisha here? Who has taken the gone with the Zahida here? Who has gone to Sesame Place and waded in that kiddie pool where Ernie and Bert is?
I've been there, Professor.
Okay, so when you wade in that ankle deep water and then compare walking on dry land, which has higher pressure?
Walking in the kiddie pool.
All right, so obviously dry land has no pressure at all, right? Now, if you wade in the adult pool now, which is now knee deep or waist deep, which is harder to walk on, the kiddie pool or the adult pool?
The adult pool.
All right, so therefore, can you say that the higher the height of the water, the higher the pressure?
Yes.
Yes. So that explains why when you see suction pressure, that's centimeters, 20 centimeters, 40 centimeters of water suction, that is equivalent, the centimeters there is literally the height of the pressure imposed by the height of the water. Meaning when a suction says 20 centimeters of water suction, that means the pressure applied is equivalent to the pressure of the height of the water that is 20 centimeters high. Does that make sense? That is the amount of pressure that is applied to the patient. So if there is 20 centimeters high of water in this bottle, how much pressure is the patient receiving?
20.
20 centimeters of water pressure. Does that make sense?
Yeah.
Okay, so again, this is called a wet setup because of the third bottle. The third bottle is wet. It has water in it. And the amount of suction applied to the patient is measured according to the height of the water here. There's also a dry setup like this one. Here, this is called the Atrium Oasis. Oasis is found in the desert, right? So it's dry, so that's the name they call it. It's Atrium Oasis because this is dry. So this is bottle number 1 here. We have 3 columns, 1, 2, 3. This is bottle number 1, bottle number 2. Okay, B, this is bottle number 2. This is your water seal, allowing air to enter here, escape through here, but cannot come back. And then now this is your third bottle. As you can see, it's not wet, it's dry. It's measured by this dial, it's controlled by this dial here. So you have here 10, 20, 30, 40 centimeters of water pressure. So you simply dial this arrow to the desired pressure. And that is now how you control the section applied to the patient. So this is called a dry setup. This is a dry chest drainage system. This one here, which is tiny, I can't enlarge it, but can you see this kind of, sort of? The ocean. So this is called the Atrium Ocean. You know, ocean is wet. So this is bottle number 1, still 3 columns, 1, 2, 3. This is bottle number 1. This is still column B, or bottle number 2, water seal. And this is now C. This is your suction control bottle. Not very clear, but you'll see 5, 10, 15, and 20 centimeters of water here. So this is literally the height of the water column. It doesn't matter how much water is in there. What matters is the height of the column. So if you fill the water that the column up to 5, 10, 15, or 20 centimeters of water, that is the corresponding amount of suction being applied to the patient. Any question between a dry and a wet setup? Again, what makes it dry or wet is the third bottle. It's based on the suction control bottle. So what we did is package the 3-bottle system, package this one, the 3-bottle system, because this is not very practical. For one thing, these are small bottles. This is only 1 liter capacity bottles. They are sterile. We can reuse these, so environmentally friendly. We can autoclave them, say for, you know, we can use them again on another patient in the future. However, it's not, again, very practical because it's only going to hold 1 liter. That means you're gonna have to change the setup almost every day or maybe twice a day. Whereas the commercial one can be one box, maybe enough for the patient's entire stay in the hospital. Unless, of course, the drainage is a lot, then you may have to change the system once or twice during the admission. Again, let's recap. Bottle number 1 is where all the fluid, anything wet coming out of the thorax is collected. So this is bottle number 1. Bottle number 2 is the air trap or the water seal. This is very important because this will protect the patient from another pneumothorax. It will prevent air from returning into the chest. We want the air to come out, not go back in there. So therefore, the water seal must contain water. There should be at least 2 centimeters of water in there, 2 centimeters high in order for it to be effective. And then the third bottle, again, does not apply suction. It only controls the suction. So you still need an external suction source in order to apply the suction. The bottle simply, or the chamber simply controls the amount of suction. So, Miss Ashley. Miss Ashley here? Miss Genius?
Yes, I'm here.
All right. So if I put the wall suction, so I connected the system to the wall suction, and I put the wall suction to 120 centimeters of water pressure. However, my height here in the setup, I filled it up to the 20 centimeter line. How much suction is the patient receiving? The third chamber is filled up to 20 centimeters high. The wall suction, however, I dialed it all the way to 120 centimeters of water pressure. How much pressure is the patient receiving?
Your microphone keeps going in and out, so I'm missing every time you're telling me the pressure.
So I filled the third chamber up to the 20 centimeter line with the sterile distilled water. The wall suction to which it is connected, I turned the dial up to 120 centimeters of water pressure. Question is, how much suction is the patient receiving?
Would it be 20?
Very good. It's not the wall that determines the amount of suction. It's only the water in the third column, in the third chamber, in the third bottle. The height of the water there will determine how much suction the patient receives, because it's the suction control chamber. If it's a dry setup, like this one, so obviously the third bottle here is not wet, it's dry. So therefore it's the dial here that determines the amount of suction. You simply turn the dial to the ordered amount of suction. It is, the doctor doesn't write an order. The default pressure is always 20. Again, in the absence of a doctor's order, the default pressure for any chest tube is 20 centimeters of water. Now let's go to nursing care. Let's go back to chapter 30. All these are explained here. Let's go to how does it work. Okay, I mentioned this earlier that the water seal, which is the bottle number 2, must have a minimum of 2 centimeters of water in there. It's important that there's water there. Why again? Why should there be water in the second column?
Because it traps air and protects the patient from
Very
pneumothorax.
good. That is your water seal. So that protects the patient. That is very important. Now, bubbling. Now, there will be bubbling in anything wet. So there will be bubbling in the, if you imagine the second column as well as the third column in a wet suction setup. So you have 2 chambers here there that are wet. Now, as far as the water seal is concerned, the water seal chamber, which is bottle number 2, which is your trap, your water seal, the bubbling there should only be intermittent, and it should bubble also during exhalation, coughing, and sneezing, which makes sense. Remember, the tube is in the thorax, it's in the pleural cavity. So when the lungs, what do your lungs do when you exhale, when you cough, or you sneeze? What are your lungs doing? Are they filling with air or emptying air?
Emptying.
Emptying. However, before it can empty, what must the lung do?
expand.
It has to fill first before it can empty, right? So that's why you can't cough if you can't breathe, correct? That means if you're coughing, you can breathe because it's impossible to cough with an empty lung, correct? Right. So if you think about it, before you cough, you go like this. So that means when you inhale, the lung expanded, pushing whatever air or fluid is in the pleura out through the chest tube and out into the water seal, into the rest of the column. Make sense? So therefore, it's normal to see bubbling that is only intermittent and occurring only when the patient exhales, coughs, or sneezes, or yawns. Okay, you can add yawning there because yawning also you're also inhaling, right? It's a really deep yawn when you deep breath when you yawn. So therefore, there should be bubbling during those instances. If there is a continuous bubbling in the water seal chamber, that only means two things. One, there is an air leak, meaning somewhere in your system, from the chest tube all the way to the drainage collection device, there is a leak. You did not have an adequate seal. The leak usually occurs at two places. One is at the chest where the patient is having the chest tube inserted. Because remember in the video, did we create a circular incision to put a round tube in there? Was it a round incision?
No.
No, it was a straight vertical incision. So you put a round tube through a vertical incision. Is there going to be a perfect snug fit?
No.
No, there will be a leak around there. So the only way you can seal that leak is to put something impervious to air in there, like a petroleum gauze. A petroleum gauze is literally gauze with petroleum jelly. Okay, so it's oily, right? So if you have something like that, can air pass through something oily? No, that is impervious to air. So that's what we wrap the insertion site with. And then of course we put a drain sponge in there and secure it. Of course, whoever put the dressing in there must not have done a good job wrapping the insertion site with petroleum gauze. That way, that's the reason why there could be a leak there. The other source of the leak is at the connection between the chest tube and the drainage system. When I stopped the video earlier, the last scene was when the narrator said the chest tube is now connected to a water seal collection chamber, right? So that point where there was an adapter attached to the chest tube, we tape that connection right there. So that's the other source of a possible leak. Whoever taped it probably used plastic tape instead of foam tape, or paper tape also. Paper tape can also leak. So the appropriate tape to use in that connection is a foam tape. Foam tape is, I'm sure you guys have seen a 3M wall hanger. You know, those hooks that you buy you put on the wall to hang your clothes pictures. Yes?
Yep.
Those 3M hooks. Okay, so the adhesive on the back, if you notice, if you peel that thing off, it's made of foamy, stretchy stuff, right? Where the adhesive is, it's foam, right? And it's stretchable. So that is the foam tape. We have those in clinical. We have those in different sizes. We have 1 inch, 2 inch, 4 inch, wide foam tape. So we need to wrap it with foam, adequate airtight seal on the connection. So that's the only time bubbling is seen normally there. The only other time is if this is the patient has a large pneumothorax and you had just connected the patient today, that the chest tube was inserted today and you had just connected it to the drainage system. Of course, as all that air escapes for the first hour, you'll have continuous bubbling there because you have a lot of air coming out at once. So of course, you will see a lot of bubbling in the water seal. However, as soon as all that air is removed, the bubbling should stop. The bubbling should only occur during exhalation, coughing, sneezing, or yawning. A blocked or kinked tube will also cause bubbling to stop. So let's say you walk into the patient's room because the tube, the drainage tube in the drainage collection system is 6 feet long. It tends to lay on the floor. So when you're at the bedside, we sometimes, in our busyness, we may be stepping on the tube. It happens. The height of the water also in the water seal, we're still talking about chamber number 2 here, or the water seal tube, will also tidal. I wish we were in class so that I could demonstrate how it is. You will actually see the water level in the second chamber. In this bottle right here, this will rise when you inhale as well. It will also rise or tidal, go up and down. It would tidal also during coughing, sneezing, yawning, and exhaling. It will also tidal up and down. Right, so I'm telling you first about bottle number 2. So what's expected, what's not expected in that column. Any questions so far? Okay. So it's normal to see what type of bubbling in the second chamber? The bubbling. Intermittent. Very good. Intermittent when?
Intermittent when we sneeze, when we cough.
Or exhale or yawn. And it should also tidal. Okay, it will go up and down. And not visible in the picture is a tiny plastic white ball. By the way, the system has a dye in it. So when you pour in when you aseptically add sterile distilled water in it, the water becomes blue because there's a dye, there's a powder dye in the box. So when you fill it, anything liquid automatically turns blue because it's hard to see if it's clear. There's no way you can see the tidling if the fluid is clear. So it's colored blue, so you can see the tidling, the bubbling, etc. And now because it's blue, now you can see a white plastic ball that will go up and down. That way you can see, it will also help you see that it is tidling, okay, when the ball moves. It's a tiny little plastic ball. Okay, let's go to the chamber 3. Chamber 3 in a dry setup is boring because it's just a dial. So you dial the arrow to 10, 20, 30, or 40. Those are another difference between the wet and dry. In a dry system, the highest suction you can apply is up to 40 centimeters of water. In the wet system, the highest it can give is only 20. Otherwise, your box will be really tall in order to add up to 40. Okay, so that's another difference. So number one difference is the wet setup is wet. I mean, I'm talking about chamber 3. It's wet. In the dry setup, it's dry. That's why it's called dry. The other difference is the amount of suction. The dry setup is capable of giving up to 40 centimeters of water suction. The wet setup only has a maximum of 20. And what I hate about the wet is the water evaporates because you connect it to suction. So the water will eventually go down to 18, 15, 10 because it evaporates. So that means you have to keep adding water in there to maintain a suction of 20 centimeters. So that's another thing I don't like about the wet, because you have to keep adding water to it, because otherwise your therapy is not optimal. Your suction, the amount of suction goes down as the water evaporates. So we already said this, for either type, the amount of suction applied to the patient is not determined by the wall, but by the device. The third column determines the amount of suction. So in a wet setup, of course, because you attach the system to the wall suction, of course, as the wall suction applies it to the system in a wet setup, the third column will bubble. It will constantly bubble because you are applying suction to it. So again, the third column will in a wet setup will constantly bubble. This one right here. Okay, this is your water seal, right? This bottle number 2. This is your third column. This is the wet setup. So when this is connected to a wall suction, this column here, only this column here, will constantly bubble like crazy. In the higher the suction, the more violent the bubbling. All right, so this will constantly bubble. So it tells you that the system is connected to suction. If there's no bubbling here, what does that mean? Right here, this stops bubbling.
Probably got disconnected from the wall suction.
Very good. There is no suction. We need to check the connection, making sure is the wall suction working, because there is, the only way you know that it's connected to suction is if this is bubbling. So no bubbling, either there's a kink in the connection between the wall suction and the system, or the wall suction is defective. Okay, there's no suction, or maybe the wall suction is off, right? So this one again should bubble constantly. Of the dry setup, then there's nothing will bubble.
So, Professor, is there a problem like sometimes there's no bubble at all in the third one? That means maybe either the suction, wall suction problem, or at the connection?
Yes.
Both the side, right?
Yeah, either. You just investigate what's wrong, but it should be bubbling in a wet setup. There should be bubbling, constant bubbling. All right, so what do we need to have at the bedside? So each patient with a chest tube must have a padded clamps in there at the bedside. You need 2. There should be 2 padded clamps. There should be gauze there. There should be sterile gauze, dry sterile gauze. And you should also have a bottle of sterile distilled water in there. And of course the tape, okay, the foam tape. Again, what are the things you should have there at the bedside? Tape, foam tape, dry sterile gauze, a bottle of sterile distilled water, and 2 padded clamps. Okay, I'll show you how to use them later. Therefore, are emergencies. All right. So there are 3 things we take care of in chart 30-12. So we have the system, we have the what is this? The patient, the system and what to report to the physician. Okay. One at a time. For the patient, simple. You medicate, this is painful, you have a chest tube there. If they report burning sensation, keep position them, because that means the tube is rubbing against the lung. So just find a comfortable position. You give them pain medication. You assess vital signs, lung sounds, etc. You check, because we change the dressing daily. Check the insertion site for signs of infection. Or there could be air entering the subcutaneous layer. We call that subcutaneous emphysema. I mentioned infection. This is the islets I mentioned earlier. So that means if you see islets, what's happening to the tube? Is the tube in place?
Oh, it came out.
It's an emergency, you said, right?
Right, it was accidentally or intentionally pulled out, I don't know. But it's no longer in there. So call a physician if you see that. Same thing, the patient can ambulate, by the way. They don't have to stay in bed. Okay, you can take them off the wall suction. It will still work. It will still change gravity if they're walking. So don't say, oh, they need to be in there because the suction needs to be on. No, you ambulate the patient. That's even better than the suction, right? Chest expansion is only if the patient is in bed, then of course you have to connect it to suction. But please encourage them to walk. Okay, ambulate them. They can carry the tube just like a Foley. So just make sure that the box is below the chest. Okay, just like a Foley bag would be below the bladder. All right. So I mentioned earlier that the tube in the system is 6 feet long. There's no way to cut it. You can't without disturbing the integrity. If you cut it, then that means it's no longer sterile. So there's no way to shorten the tube. I'm not talking about the chest tube, okay? I'm talking about the drainage system, the connection tube. Now, the material of the tube is also made of rubber. The same rubber we used on the top of the vial. Do you know what I'm talking about? Medication vials, the top, the rubber part, you can stick that with a needle, right? And it doesn't make a hole, it closes after you remove the needle. It's a self-sealing rubber. The tube, the connection tube is made of the same material, meaning you can stick it with a needle as long as it's a sharp needle. And then when you remove the needle, it will close. Right? It's necessary sometimes because the doctor will ask you for a specimen. So that's where you get the specimen through the tube. Just like a Foley. When somebody has a Foley and you need a urine sample, do you know what I'm talking about? Can you picture what I'm saying?
Yes.
Yes.
All right. Because the tube is long, it will have a dependent loop, meaning
Bending something.
let's say this is the bed. That's the, okay, this is the box. Okay, this is the drainage box. So the chest tube, of course, is attached to the patient, and the drainage tubing to the collection device, because it's 6 feet long, it will tend to fall like this before it goes to the box. So you have a dependent loop right here. So when you have blood or any other liquid, especially blood, when blood pools here, can it directly go in there into the box?
No.
No. So the blood will tend to pool down here. 6 to 8 hours later, what will happen to that blood? Is it still blood?
It just coagulates?
It's now a blood clot. So it will coagulate. Now is your tube still patent?
No, they're obstructed.
It's equivalent to clamping the tube, right? Now imagine there's a patient has a pneumothorax. Is that air getting out of the patient? what could happen to this patient? What could they develop? If there is an obstruction there, a kink,
Tension pneumothorax.
tension pneumothorax, will the patient die?
Yes.
Yep.
Yes. Okay. So you need to, this is what says here, avoid dependent loops. So how do you get rid of this? Well, you can put it on the bed. Okay, so every time you make rounds, because you're supposed to make rounds every hour, just pick it up, put it on the bed.
Mhm.
Repeat every hour. That's all you can do to prevent that blood. Because if that blood coagulates there, that means how long has it been in there? Did the nurse make rounds to this patient?
No.
No. So that reflects poorly on your nursing care. That means you didn't do your job. You're supposed to make rounds every hour for this patient. So that means you never picked it up. That blood stayed there, got stuck there for who knows how long, because now it's clotted. It's obstructed due to now the patient is in tension pneumothorax. Okay, so how do we get rid of it? Okay, do not strip the tube. Strip meaning you hold it with your left finger and then you strip it. You know, you squeeze this until it reaches there. So that's called stripping. Do not strip the tube, because stripping, you have a warning here on the textbook. It's not in the chart, but it's in the paragraph below it. Right here. If any tube manipulation is needed, gentle hand over hand milking is preferred over stripping. Meaning there's no way we can get rid of that blood clot. So you have to do milking. Okay? So just gentle hand over hand, just to move that blood clot into the drainage box. All right? Do not strip, because it tells you here, stripping causes up to 400 centimeters of water pressure. That's a lot of pressure on the thorax. Okay, so no stripping. If you have to, then just do milking. Okay, let's move on. Okay, so we know bubbling is expected during coughing, blah, blah, blah. Now, as far as, okay, we also need to cease tidling. And we need, if in a wet setup, there should be enough water in there, 20 centimeters high water. So that's how you maintain the suction order. Clamping. There are only two instances that we clamp. One is to when we're checking for air leaks. It's a matter of ruling out. So you clamp and then see if the bubbling disappears, there's your leak. It's pretty simple. So this is one time. The other time you clamp is when you're changing the system, meaning the box is full. It's filled to capacity, so you need to change it to, you need to disconnect it from the old system, connect it to the new system. So that's the only other time you clamp. What are the two times you clamp again?
One with the checking for leaks
And
one with checking with the drainage system.
You're changing the system. Okay, and in both cases, you only clamp for brief periods. I mean, literally like 2 seconds. Okay, maybe 3 seconds, 5 seconds. That's it. This one, disregard this. Talking about here because the drainage collection devices are disposable. They must be talking about a water seal. I mean the bottle system, literally the glass bottles, right? Because we don't empty the thing. The only thing we empty is the glass bottle. But even that, we don't really empty it and use the same thing. We change the system. Okay? So I agree with changing the system, but not the emptying part. I don't know how you do that. I mentioned this earlier. So when you need a sample, so you just get a needle and then draw your specimen up. Of course, you have to clean the tube first, okay? The drainage tube. clean it with chlorhexidine, alcohol, or betadine. I don't know what you want to use, and then get your specimen there. Lastly, these are the emergencies that you call the physician. Tracheal deviation, and this, of course, indicates what?
Tension pneumo.
Tension pneumo. Very good. Drainage greater than 70 ml per hour. That's a lot of drainage. The exception is when it was first put in today. That's the only other time you'll see a lot of drainage more than 70 ml. After the, let's say, 8 hours, it shouldn't be. It's a lot of drainage. Patient could be bleeding. Islets, we already know. Of course, we call physician for that. Two conditions here. First, chest tube falls out, meaning the chest tube was pulled out of the patient's chest. The tube is no longer in there. What do? Cover the area with dry, sterile gauze, and then call a physician. All right. The other condition is the chest tube is disconnected from the drainage system. Honestly, I don't know how this will happen because you tape that thing. So unless you have, I don't know, Chucky goes in there. No, Chucky, the doll, the evil doll, goes in there and then disconnects it. That's the only other instance that this could possibly happen. I've never seen this happen wherein the patient is disconnected from the drainage system. The chest tube falling out, this happens all the time. This one happens all the time. This one, I've never seen this happen. Okay, except maybe Chucky. That's the only explanation. So if this happens, Chucky did it. All right. And this one, finally, call the doctor also if the drainage stops during the first 24 hours. Beyond that, it could be that the chest has re-expanded, especially if the bubbling in the water seal stops. Again, if the bubbling stops, drainage stops, but it's all in the first 24 hours, that's impossible. There must be a kink, or maybe the chest tube is clogged with a blood clot. Something's wrong if it occurs in the first 24 hours. Other than that, your evidence of chest expansion is there's no more bubbling in the as result. And that's it. Any questions?